Hello, everybody, and welcome back. Today's webinar is titled The Role of Comprehensive Genomic Profiling in Precision Oncology. I am Sydney McNeil, and I will be your moderator for today's event. Today's web seminar is brought to you by Diaceutics. To learn more, visit the Diaceutics booth in the exhibit hall and diaceutics.com. We encourage you to participate today by submitting any questions you may have during the presentation. To do so, simply type them into the Ask a Question box and click Send. We will answer as many as we have time for at the end of the presentation. Here is a brief overview of the session and this session and the one following. As you can see, Dr. Normanno will kick off the session and we will wrap up with a Q&A. Immediately following the Q&A session, a continued discussion will take place in the networking lounge via Zoom. Okay, I would now like to welcome our speakers, Dr. Nicola Normanno and Professor Clare Turnbull. For a complete biography on our speakers, please visit the presenter window at the top of your screen. Dr. Normanno, you may now begin your presentation.
Thanks for inviting me to give talk. Actually, there is a slight, I think, minor error in the program, because after my talk, we will have also a talk from Professor Turnbull and then the Q&A session. Now, these are my disclosures, and the latest disclosure that I have is that I just moved to these new institutions, the National Cancer Institute di Nomadori in Melbourne. Now, these are the topics that I will try to cover in my talk, starting from a brief overview of the tumor-specific tumor-agnostic genomic biomarkers that are available today for precision oncology. Well, as you know, in the past few years, we have observed the approval of an increasing number of precision oncology drugs. Actually, on top of this slide, there are the drugs that have been approved by the Food and Drug Administration, and on the bottom, the drugs approved by the European Medicines Agency. There is some difference, and I'll get back to this later during my talk. As a matter of fact, thanks to this approval, today, over 25%, maybe up to 30%, of patients with advanced cancer may receive a therapy that is associated to a biomarker. And we do expect that this fraction is going to increase significantly in the next few years. Indeed, almost more than 90% of the drugs that today enter clinical trials in oncology are biomarkers associated with biomarkers, so basically are precision oncology drugs. Now, most of the biomarkers we are using today in our routine clinical practice are tumor-specific. We have biomarkers for lung cancer, breast cancer, ovarian cancer, so on. But now we have a new wave of biomarkers, which are the tumor-agnostic biomarkers. This is a quite a busy slide for a very simple concept. On top of this slide, you see the many driver alteration for which we have available target therapies. And if you look at the presence of this alteration among different tumor types, it's quite evident that you can find any type of driver alteration in any tumor type, although usually these are occurs at very low frequency. So the hypothesis is that the presence of this genomic alteration might predict response to match therapy independently from the histology background. This is why we refer to these biomarkers and drugs as to tumor-agnostic biomarkers and tumor-agnostic drugs. Now, in this scenario, it's clear that it's highly relevant for cancer patients the possibility to access to biomarker testing. If you cannot access to biomarker tests, you will not be able to access to new drugs. And there are different technologies that can be used for biomarker testing. With the increasing number of genomic alterations that we need to test in our routine clinical practice, is becoming always more and more important the use of next generation sequencing. NGS is a technique that can detect different types of genomic alteration in multiple genes in a single analysis, thus improving the coverage of the mutation, but also reducing the time and the amount of tissue needed for testing. This slide shows the current, actually very recent recommendations for use of NGS in clinical practice that were released by the ESMO Precision Medicine Working Group. These updated guidelines have been published a few weeks ago. And in addition to the tumors included in the 2020 recommendations, lung cancer, prostate cancer, colorectal cancer, cholangiocarcinoma, ovarian cancer, these guidelines suggest the use or recommend use tumor NGS also in patients with advanced breast cancer, or at least selected patients with advanced breast cancer, and some rare tumors, such as gastrointestinal stromal tumors, sarcoma, thyroid cancer, and cancer of non-primaries. Now, which type of genomic alteration should we test in our routine clinical practice? What this more recommendation suggests is to test the ASCAT level 1 alteration. ASCAT is the ESMO scale for clinical actionability of molecular targets, and simply this scale puts in correlation the biomarkers with the evidence from clinical trials suggesting that the presence of biomarkers does predict response to match therapy. So in the level 1, we found that the biomarkers ready for routine use, basically biomarkers for drugs that have been approved by regulatory agency. And then in the level 2, 3, and 4, we found biomarkers with lower level of evidence. Now, since the recommendation to test only level 1 alteration, at least in clinical practice, many labs are using small or medium-sized panel for NGS testing. Small panels are most frequently tumor-specific, and they have some limitation. Particular issue is that if these panels are not updated continuously, they might not cover all the genomic alterations that are relevant in clinical practice for our patients. This is the reason why many labs are switching to the use of medium-sized panel, which cover more or less almost all the driver alteration for which there are available drugs, at least today, and that might simplify a lot the workflow in the lab. In general, the use of larger panels, 300, 400 genes, or even whole exome sequencing or whole genome sequencing is much more restrictive. We'll see in the next slides. But these panels have a huge advantage because they will provide a comprehensive genomic profile of the tumor, which means they will provide information on all the different genomic alteration, and will also allow to identify complex genomic biomarkers, for example, tumor mutational burden or microsatellite stability or molecular combination deficiency. Now, before going ahead, however, I want to underline that the access to biomarker, in particular to NGS, is highly limited in Europe. This is a survey that International Quality Network for Pathology ran in 2020-2021 in collaboration with the European Cancer Patient Coalition and the European Federation of Pharmaceutical Industries Associations. And what we basically describe is that in most European countries, there are some limitations in the access to precision medicine. Quite surprising, we found that in some European countries there are still limitations in the access to single biomarker tests. The access to multi-biomarker NGS tests is highly limited in the majority of European countries, that there are also some issues on test quality. Now, this was around 2020 to 2021. We have no evidence that situations improved much, and for this reason, the AcquaImport decided to launch this new initiative, this project on adoption, canceromic, and precision oncology in patient journey. Basically, we are collaborating with a number of academic institutions, non-governmental organizations, and industries in order to identify the existing barriers to the access to biomarker and precision medicine and propose strategies and solutions to accelerate the implementation of precision oncology with a focus in particular on low and middle income countries. We are just starting this project, and please stay tuned for the next development. But let's try to understand now which is the level of development of precision oncology in Europe and which model we could propose to improve this situation. Now, we have to say that although the use of small panels is recommended by current guidelines, there are a number of initiatives that are trying to introduce comprehensive genome profiling early in the diagnostic workup of patients with advanced cancer. For example, in Germany, a law is being approved, and starting next January, all patients will undergo comprehensive genome profiling. They will start with a large panel of over 500 genes, and then they will move to whole exome sequencing and possibly to whole genome sequencing. Similar initiatives are ongoing also in England, in France, in other countries, which large cohorts of patients will be tested with whole exome sequencing or whole genome sequencing. However, we have also to acknowledge that in many other countries, the introduction of comprehensive genome profiling in the diagnostic workout of patients is highly limited. And let me show you some examples from Italy to understand if this strategy is correct. Now, in Italy today, we offer comprehensive genomic profiling only to patients who failed standard lines of therapy or patients with rare tumors that have no other therapeutic options. So what we did to understand really how NGS is used in the current clinical practice in Italy, we opened this study, the national study, Italian Register of Action Mutations. What we did was quite simple. It's a pragmatic study. In the pathway A, we enrolled patients with advanced solid tumors who received NGS in clinical practice or in a clinical trial, so data already available. And in the pathway B, we offered the possibility to undergo comprehensive genomic profiling to those patients who had no access to NGS. What we found is that patients enrolled in pathway in most of cases received a test with a panel that was small to medium size, less than 52 genes, and this is in line with the current guidelines that suggest use such small panels in clinical practice. If you look at the clinical characteristics of patients enrolled in pathway B, it's quite evident that these patients received more previous line of therapy as compared with patients in pathway A before undergoing comprehensive genomic profiling. And again, this is also in line with current recommendation in Italy, I would say also at international level. Now, when we analyze the ability of these two different strategies, standard panels versus comprehensive genome profiling, to identify the level 1 alteration, the biomarker needed in clinical practice, there was no difference. As I told you, most of these panels for standard NGS do cover very well level 1 alteration. However, comprehensive genome profiling allowed to identify many more ESCOT level 2 and 3 alteration that allow to put patients into clinical trials. Now, when I discuss this data with the payers, the reaction is that this data clearly suggests that in clinical practice you don't need to use comprehensive genomic profiling because standard NGS will cover all the biomarkers. However, the truth is that if you want to retest patients after they fail different lines of therapy, most of the times this is not available. You don't have enough time. We will go into this. And more importantly, even, I mean, to have the possibility to enroll a clinical patient in a clinical trial is a value. Is a value for the patient, but is a value also for the institution. As the director of a cancer institute, let me tell you that the possibility to enroll patients in clinical trials is a very important part voice of our budget because of course we get a fee for patients that enroll. We have also can treat patients with drugs that are paid by the sponsor. I mean, so there are several advantages. Now, overall, we could find ESCOT levels 1, 2, and 3 alteration in a large fraction of the patients, over almost 46%. However, the result of the trial was quite disappointing. Less than 12% of patients received a therapy that was matched to the molecular alteration that we found. And this result actually is in line with many previous studies of getting almost same or even lower fraction of patients who received a target therapy based on genomic profiling. But let's try to understand what are the reasons for this failure. If you look at pathway B, the third point, the main reason for which patients did not receive a target therapy, although they carried an actual genomic alteration, was the lack of clinical trials or other pathways access to drugs, about 58% of patients. However, almost 14% of patients died before the NGS report was available, and almost 28% of patients died within 5 months from the availability of the NGS report, suggesting poor clinical condition. These patients never could get into a clinical trial and they were likely to receive any kind of therapy. So the issue is that if we want really to give possibility to patients to receive a precision oncology drug, we need to introduce comprehensive genomic profile early into the diagnostic workup of these patients. The issue is, however, that we need also to solve the problem of the availability of drugs. So we need to open clinical trials. And actually, there are some examples. For example, in the Netherlands, patients undergo whole genome sequencing, and based on their genome profile, they are assigned to different cohort of treatments shown in this slide. Now, this is one of the many trials that have been opened of precision oncology in Europe. What I want to underline that based on the results of one of the cohort of this study, is more than 1 year that Dutch health authorities do reimburse the use of nivolumab for patients with microsatellite instability independently from histology, so a tumor-agnostic reimbursement that is not endorsed by EMA. Now, while we have to congratulate with our Dutch colleague for this success, we must also underline that this kind of approach will lead to significant disparities in access to drugs between patients of different European countries. So it's clear that we need to develop a different model, and in particular, what we need to do, that's at least my proposal, is to involve patients, pharma industries, and also academia, and also regulatory bodies at the European level at the beginning when we plan these trials, so that the data coming from this trial could be used for early approval of innovative drugs at the European level. Here, however, comes another issue, which is the level of evidence that we need to approve new drugs. And this slide suggests that the level of evidence requested by the FDA and EMA is quite different. On the right, you see that many tumor-agnostic drugs have been approved by FDA in the past few years, and I have to update this slide every 2 to 3 months. On the left, for a long time, we had only one biomarker in drug fusions and 2 drugs, larotrectinib and entrectinib, approved by EMA. A few weeks ago, March 26, the CHMP of EMA released a positive opinion for the use of cell-per catering in patients with red fusion-positive tumors. We will see whether this will change somehow the approach of EMA to tumor-agnostic biomarkers, but it's quite evident that there is a difference. The issue is that when we are dealing with very rare genomic alterations, it's difficult to have a large number of patients. It's difficult to have randomized clinical trials. Most likely, we will need to accept to have some kind of provisional approval coupled with the use of data from real-world evidence. And to show you which is the power of this real-world data, I will show you just an example for the tumor mutational burden. TMB has been approved as tumor-agnostic biomarkers for the use of pembrolizumab by FDA based on this clinical trial, in which only 102 patients had high TMB value, and as shown in this slide, only few tumor types were really represented in this trial. Now, Foundation Medicine has a genomic database over 400,000 patients with cancer. Flatiron has a clinical research database over 3 million patients. When they put together these two databases, they came out with over 100,000 patients with the clinical genomic data, and these are the results. For TMB, you see that with a much higher number of patients as compared to the clinical trial, it is confirmed that the presence of ITMB predicts response to immunotherapy in a number of tumor types, including histological types that were not included into the initial clinical trial. So this is really the power of real-world data. But let me say also that using comprehensive genome profiling can provide important information also on tumor heterogeneity. Now, today we simply classify patients based on a single genomic alteration, but we know that even with the best driver, we know that the best, the response rate will be 70 to 75%. A minimum patient will respond. There is high variability in the deepness of response and duration of response. So it's clear that this approach using a single genomic alteration does not recapitulate the heterogeneity of cancer. Now, if you use comprehensive genome profiling, you will find that tumors carry many genomic alterations. Even tumors with strong driver alteration have co-mutation. This is clear because you need at least 4 to 5 genomic alterations to occur in the same cells in order that the normal cells becomes a transformed cells. And now we have increasing evidence that the presence of this co-mutation massively affect the response to target therapy. These are examples in lung cancer, for example, in many other tumor types. Why is this important? Because now we start to have different options, and use of these co-mutations and those information from liquid biopsy is very important to better certify our patients. Let me show an example again coming from liquid biopsy. Today we use liquid biopsy only when tissue is not available or when a fast turnaround time is required. But as a matter of fact, tissue biopsy and liquid biopsy can provide complementary information. This, for example, is a clinical trial of osimertinib plus chemo versus osimertinib monotherapy. In both the arms of treatment, the presence, the detection of plasma EGFR mutation, so the patients were ctDNA positive, do worse as compared with ctDNA negative patients. So this is a clear prognostic biomarker. We don't ever use prognostic biomarker today in precision oncology. We only use predictive biomarkers. However, if you look at on the left, in the ctDNA positive patients, osimertinib chemotherapy does better than osimertinib alone. And on the right, which you have on the ctDNA negative, there is no difference between these two types of therapy. So in patients with worse prognosis, we can think to use combinations that are more aggressive, more costly, more side effects. In patients that have a better prognosis, maybe the use of single agent will be sufficient. And I think this is important advancement. And finally, I will just touch on this that will be discussed by Professor Turnbull in her talk. But if you use comprehensive genome profiling, you will also sequence genes that are associated with hereditary cancer syndrome. These are the results of our study. Almost 12% of patients carry the potentially germline pathogenic like pathogenic variant, but there are other studies in line with these. For example, this is analysis of large number of patients, and even patients like lung cancer who usually do not undergo genomic profiling, may carry some of these potential germline variants. Is this going to make any difference for our patients? Most likely no, but it will make a huge difference for the families because we can identify families with hereditary cancer syndromes in which we can make a difference. We can severely reduce mortality from cancer. So getting back to my proposal is that we could use this structured real-world clinical genomic data to reassess the initial evaluation of new drugs and confirm this, the approval may be restricted also to some subpopulation, and the approval of new precision tests at the end will force them further use of comprehensive genomic profiling, so creating a cycle that will increase the progression of precision oncology. My conclusion, largely anticipated, biomarker testing is essential to guide therapeutic strategy in cancer patients, and comprehensive genomic profiling not only can provide you information on all the approved biomarkers, but it can increase the chance of patients to access new therapies through clinical trials, provide relevant information on tumor heterogeneity, which is essential to move on and improve personalization of treatments, identify families with hereditary cancer syndrome. I think that in the future, combination of predictive prognostic biomarkers will be essential to allow better stratification of cancer patients, and this model of early provisional approval of precision medicine, coupled with collection of real-world clinical genomic data, may contribute to accelerate the access of patients to novel therapies. My very last slide is to thank all the collaborators of my previous institute, of the next institute, and now leave over to Professor Turnbull that will discuss reporting and management of germline findings in NGS. Claire.
So good afternoon, everyone, or whatever time it is, wherever you are. Welcome. So I'm very pleased to be able to follow on from Dr. Normanno and talk about the implications of potential germline findings when you're conducting tumor-only next-generation sequencing. So I'm a clinical geneticist. I'm not an oncologist. I work in a cancer centre, but I see patients and families from the perspective of the heritable genetic changes relating to their cancer diagnosis and management. So those are my disclosures. And the work I'm going to be presenting today is the output from an ESMO Precision Medicine Working Group subgroup convention, which brought together these 8 individuals, so a number of the ESMO Precision Medicine Working Group oncology representatives, but also then Diana Mandelker, George Bergel, and Angela George and myself, coming from a particular molecular pathology and germline perspective. And we were very fortunate in writing these recommendations to work with the team at Memorial Sloan Kettering, with being the collaboration being led by Diana Mandelker. So we were able to analyse the MSK impact data. So that's matched tumour normal paired sequencing on almost 50,000 different tumour samples. So that gives a sort of truth set where we can look at the ground truth in terms of the genuine germline status of what you may or may not see in the tumour, because nearly always in clinical practice, we're doing tumour-only sequencing. So the MSK data gave us the the true answers by which we could base our recommendations. So these recommendations were published last year, and this is an update on some earlier recommendations convened by the ESMO group, published in 2019. So I'll go through 6 main themes in this talk, and the first of which is that germline follow-up requires a balanced approach. And I say this because identifying germline pathogenic variants is very important, particularly in some genes. It may influence, of course, we know how we manage the presenting cancer. We may particularly use different drugs. We may exclude 5-FU, for example, if we know there's a mismatch repair defect in the tumour. Conversely, we may base our drugs in terms of PARP inhibitor choice or platinum if we know that there is a germline BRCA1 or 2 pathogenic variant in the patient. So it's important in that regard, but that's relatively infrequent. The germline findings largely influence downstream issues, so management of future cancer risk in that patient. So that may possibly contribute to their surgical management, i.e. a colectomy or mastectomy up front, rather than more conservative surgery. But most often those risk-reducing cancer surgeries happen downstream of the main cancer management. And as Dr. Normanno said, much of the benefit is in testing in family members when we identify a germline variant. So what we don't want to do is spend lots of time and energy chasing and worrying about germline variants when we delaying, how we process the molecular data, which will inform on the management of that patient. So we really need to use our time and resource very carefully and think about the priorities in terms of the information that's most important to the oncology clinicians and the MDT there and then about decision making. We also need to think about resource as well. So we don't want to be putting undue burden on the molecular genetics lab in having to review and classify, dozens and dozens of germline variants that are or putative germline variants which are unlikely to be clinically relevant. We need to think about resource in genetic services, which are usually very small. So again, not making inappropriate referrals, and also the patients having active cancer treatment. So we don't want to divert them with inappropriate or unnecessary worry about germline issues if that is not appropriate or required. So the second point, so just which variants should we be thinking about that need what I call germline follow-up, and I may use the term putative germline variants. So this is, of course, what we see in the tumour. And if, for example, in the Memorial study, or if you have paired tumour normal, you can see very clearly, because you have the paired data available, which variants are germline, are constitutional in origin, because they will be present in both samples. So the yellow variant on the left is an illustration of what the variant findings would look like if the variant was constitutional. You would see it both in the tumour, because it's present, having been constitutional, but it would also be present in the germline sample, the blood, saliva, or normal tissue. And on the right, we have a somatic and acquired variant, which therefore is only present in the tumour and, of course, not present in the normal sample. That's if you have both samples to compare up front, that makes life relatively easy. But if you only have the tumour sample, you can see that actually it's virtually impossible to differentiate between a clonal variant that is in the tumour that's blue, particularly if it's a reasonably tumour-rich sample, versus a constitutional sample. So the factors that help us differentiate which variants are more likely to be germline in origin and which ones are worth thinking about for potential follow-up are, firstly, let's just focus on rare variants. There's lots and lots of SNPs, single nucleotide polymorphisms, that will be observed in the tumour because they're present in the germline, but we're not interested in those. So firstly, let's get rid of all the common stuff. Secondly, we are only interested in following up pathogenic variants. So again, even if a variant's rare, if it's not clearly pathogenic, we don't want to follow it up. We don't want to divert resources. We're not looking for VUSs in the tumour. So again, we want to focus on variants that are pathogenic because we know that from their mechanism. So if a variant's loss of function, it is usually pathogenic, not always, but usually. Or secondly, if it's very clearly classified as pathogenic in a reliable resource such as ClinVar, so pathogenic or likely pathogenic. So let's only focus on those types of variants and not waste resource chasing up variants that are common or VUSs. And then the third thing that can help us is variant allele frequency. And these plots are from the Memorial Sloan Kettering data, so that you can see we place a cutoff of a VAF, a variant allele frequency of 0.2, and that's for INSDELs, and 0.3 for base substitution. So you can be a little bit firmer, place a slightly stricter cutoff if it's a base substitution, be a little bit more inclusive, a bit more forgiving for INSDELs. And by doing that, that is a very efficient way of getting rid of a lot of variants that are almost invariably not germline in origin. So this is the data from the Memorial series. So our final data set was 45,000 tumours. And we firstly got rid of all of the common variants. And then the step 2 was getting rid of the non-pathogenic ones, so retaining only the ones that were truncating, lofty, or at least 1 star on ClinVar. So that's a very good way of restricting down. And then the third step was getting rid of those low VAF variants. So you can see how we've gone from hundreds of thousands of variants in the data set down to a reasonably modest number, down to 21,000. So that's only one variant that needs follow-up in about every 2 samples. And we call this the germline conversion rate. So if we get rid of the common variants, then that gives us a germline conversion rate of about 10%. And then if we get rid of the if we get rid of the non-pathogenic variants, that takes us to a germline conversion rate of 10.5%. And if we get rid of the low VAF variants, that boosts that conversion up to 16.5%. So you can see on the top line, we've got rid of about a third of the variants were low VAF. And on the bottom line, you can see that we've lost very, very few true germline variants by doing that. So that is an efficient way of restricting down the search set. So that we could just stick at that. That would be a reasonable approach, but actually there are more things that we can do to stop diverting unnecessary resource towards following up of germline variants, aside from just looking at pathogenicity and variant allele frequency. So if we start looking at individual genes, we can see that they're quite different in that germline conversion rate. So this is what each gene looks like once we've applied those rules. So we've got rid of all of the common variants, we've only retained pathogenic variants, and we've got rid of those low VAFs at the 0.2, 0.3 cutoff. So this is the final variant set. So looking at, having done all those steps, what that germline conversion rate. So remember I said it's 16.5% overall, but that's not consistent between different genes. So you can see here, I've highlighted at the top, you can see BRCA1 and BRCA2, applying those steps, you get a pretty high germline conversion rate. You're up here at about 80%. So if you apply those rules, 4 in 5 variants that you find after applying those rules will be truly germline in origin. So those are genes with a high germline conversion rate. Conversely, there are quite a few genes even after applying those rules, getting rid of the non-pathogenic, the variants that look non-pathogenic, getting rid of the variants that are of low VAF, even after doing that, genes such as NF2 I've highlighted and TP53, they just have such high rates of somatic mutation that proportionally the germline variants are very, very rare. So you can see here, TP53 is a great example. We just know that there's such a high rate of somatic mutation that even if you apply those rules, it is less than 1% of the variants going through those filters will be truly germline in origin. So then there are a few things which, again, you would imagine you're going, okay, well, what if we do the things that we know would enrich for germline variants? So let's look at young age patients. So we did this in our analysis, and you can see actually for some genes that by restricting by age, so for example, you can see here with RB1 and TP53 that as you go down in age, you really do enrich for the variant being germline in origin. And that's because we do know that germline tumours associated or tumours associated with germline variants in these genes are particularly enriched for in younger age, but that's not necessarily true in all germline genes. So there are a handful of genes, and again, they're listed in our recommendations, where actually if you happen to have a young patient, we would advocate following up the variant, whilst we wouldn't in an older patient. So you can see here for TP53 how those proportions really increase below 30 and then further increase below 5. So the next thing that we also think about is on-tumour and off-tumour germline relationships. So we mean this on-tumour is where the gene is implicated in causing germline susceptibility to that cancer type. And therefore, if we found a germline variant, we might say to the patient it explained or partially explained the cancer with which they presented. Off-tumour is that the gene is not implicated in germline susceptibility to that cancer type. So we would say that the germline finding is coincidental, and sometimes the term incidental finding or secondary finding is used. It's a little bit nuanced to the patient because they may have a gene that's implicated in their current cancer, but actually a lot of the relevance is around their risk of future cancers. So you could have a patient who had a colorectal cancer and you found an MSH2 pathogenic variant. So we'd call that an on-tumour association, and we'd say that it partially explained the colorectal cancer, but also maybe gave this woman information about her future risk of endometrial cancer associated with MSH2. So that's an on-tumour scenario. However, if this woman had colorectal cancer but had a BRCA2 pathogenic germline variant found on her tumour testing, this would give us information about her future risk of ovarian cancer and breast cancer, but we'd call this off-tumour. So maybe to the woman, these two types of information are equally relevant, whereas as germline geneticists, we have sort of sometimes managed these two situations differently with the on-tumour testing and off-tumour testing as per these two different genes. And that's not a solved issue. There's quite different practices and perspectives on that, which genes you test in which scenarios. So just to highlight, in our recommendations paper, we do give a grid that may be useful in terms of aligning. So the black dots in this grid show the on-tumour associations. The grey ones are the pathogenic variants that were detected in the data set. The next consideration is about germline actionability. And I know we talk a lot around oncological actionability. So you have oncogenicity and therapeutic actionability in terms of oncological management. We then have the actionability of the germline findings in terms of mitigating the risk of future cancers. So the factors that would influence how actionable we feel a germline cancer susceptibility gene to be is how large are the associated cancer risks, how robust and certain are those cancer risks. And a lot of the data on some of the rarer cancer susceptibility genes it comes from studies which have quite biased ascertainment, and those risks are often not reproducible, whereas maybe for genes like BRCA1 and BRCA2, the studies have been performed prospectively in unselected cohorts and are more robust. And then the other factor is, well, what can we do to mitigate that risk? So what is the evidence around screening, surgical prevention, or chemo prevention around the interventions that we're offering on the basis of that person having a germline mutation? And again, the evidence for screening for different cancer types is quite variable in terms of its robustness. So again, within our working group, we started what many of you may be aware, the ACMG 2015 secondary findings list, to which a couple of genes we added in regard of them having hadn't been updated, but we felt to be clinically actionable genes of importance. So, for example, RAD51C, RAD51D. We pulled out of this gene list 7 genes which we felt to be particularly actionable amongst the total of the ACMG list, and they're highlighted in red. So BRCA1, BRCA2, MLH1, MSH2, MSH6, PALB2, and then RET for the high-risk mutations. And then the remainder of genes would be genes we do test for in clinical cancer genetics, but we call these standard actionability. So that relates, as I said, to the magnitude of risks, the confidence and data underpinning those risks, and the evidence for the utility of the interventions we offer on the basis of those risks. And then the final consideration is defining a strategy for your clinical service. And again, in the paper, we published 4 different strategies because we felt that internationally there was quite different practice in around returning germline findings, and no practice was particularly right or wrong. There were just different levels of conservatism. So we had strategy A, and we gave the data around the germline conversion rate and the proportion of individuals who would have a germline finding and so forth under these different strategies. So strategy A would be returning all germline findings in all patients, regardless of whether they're on tumour or off tumour. Strategy B would be returning germline findings for the high and most actionable genes regardless, but only returning them on tumour for those standard genes. So that would be reducing secondary findings for genes where we're not as confident around the evidence for actionability. Strategy C would be only returning germline findings on tumour, except for those highly actionable genes that we're very confident in. And strategy D would be only returning germline findings when they're on tumour, full stop. And then we also highlighted that you could have different strategies in terms of the threshold of evidence around the germline conversion rate. So you could put a 10% or a 5%. So we presented all these data to give the readers, the users of the data, information on the implications if they took different strategies, but we recognize that different countries will have different positions around return of secondary findings, and particularly in the US, there is more of a standard practice, more of an onus to return secondary findings on all those genes regardless. So I think that's me. So my final slide is really to say that it is really, it's about having a strategy for dealing with the germline findings or putative germline findings on your sequencing to decide how you follow them up. And that needs to involve a multidisciplinary approach. So you need to involve your molecular genetics lab because they need to review the variant pathogenicity. So they need to have expertise in germline variant classification. So the putative variants are going to be followed up. They need to be reviewed to confirm that they are pathogenic. They may be on ClinVar, but to do that second check, because you don't want to alarm the patient if it's not something you're going to manage anyway. And then you need to have a clinical workflow for following up with the patient. So you'll need to acquire a germline sample. So that may be a blood sample, it may be a saliva sample. You need some information giving and genetic counselling around the implications should they get a positive germline result. You need to take informed consent. You need a pathway for returning the germline results, and you need appropriate longer-term follow-up for the patient and their family. And all of these things need consideration and mapping. Otherwise, it will end up being very ad hoc and divert resource unnecessarily and inappropriately unless the return of putative germline findings is well managed. So those are the subjects I have covered in my talk. And just to point you again, all of that is contained within these ESMO recommendations published last year, with lots of different types of data and presentations, which we hope will be helpful. And just to acknowledge the Precision Medicine Working Group subgroup who worked together on these recommendations. Thank you for listening.
All right, wonderful. Thank you, Professor Turnbull and Dr. Normanno, for your very informative presentations. We will now move into the Q&A portion of the webinar. It looks like we have a few questions already, so let's go ahead and jump right in. This first one is specifically for Dr. Normanno. What is your opinion on biomarker-based multi-cancer early detection tests? Do you foresee this technology being clinically relevant in the near future? And what will be the impact in precision medicine?
Well, it's not really a topic that we have discussed today, but it's clear that this is an intriguing possibility. We today have screening programs available only for few cancer types, which they are affected, like breast, cervical cancer, colorectal cancer, and to a lesser extent, I would say maybe prostate or lung cancer. So the possibility to get early diagnosis with the multi-cancer early detection test will be very relevant. However, there are different issues that need to be solved. And one is not only the sensitivity, but also the specificity. You know, when we talk about specificity in a patient with cancer is relevant, but when we have an individual with no evidence of cancer, it's really highly relevant. We don't want to have any kind of false positive because this will generate, psychological stress, a usual medical examination. So I think there's still a long way to go, but most likely we will get to that. The other issue will be also, the cost. So maybe we could think to use this assay in high-risk population. We are launching a program in families with hereditary cancer syndrome that could be useful. But in the general population, the cost is an issue today.
Can I come in on that, because I come from a public health background. So there are technologies. So certainly the most of the MSEDs, the genomic and methylation type tech, absolutely incredible, fantastic technology. But it's absolutely critical that you sort of zoom back and think about those Wilson-Jugner criteria for screening. And at the moment, the data on the MSEDs do raise questions. As Dr. Normanno has said, they have really relatively poor sensitivity for early stage tumours, which is exactly why we would go out and be screening in the general population, would be with the intention of detecting tumours earlier than they would present symptomatically, with the anticipation that by doing so that you would improve mortality and or quality of life. So that would be the intention. And seemingly, it does seem that for many or most tumour types, the early stage tumours do not have significant amounts of ctDNA detectable in the blood. There's also good data showing that actually, particularly for tumour types like pancreatic, esophageal, gastric, these are tumour types where actually the prognosis in early stage tumours is pretty poor. And these are the tumour types where the MSEDs perform better. And that's actually probably because our current way of staging them means that actually these often do have distant disease already. And that even when the tumours look early stage, the data from some of the MSED studies show that stage for stage, if they're ctDNA positive, they have a poorer survival than being ctDNA negative. And of course, as Dr. Normanno has said, the issue around positive predictive value, that because you don't have site specificity, these patients need quite a long follow-up. So potentially, individuals may wait months and months believing they have cancer, because you actually need to do a whole barrage of tests in order to confidently exclude it. So with a public health hat on, obviously, it would be fantastic to have a single blood test that robustly detected a large number of cancers early and improved mortality. But I think we need to be very, very cautious, because there are so many issues there if we were to get it wrong.
We will get to that. I mean, technology is improving, so we will get to that, I'm sure.
Well, the technology is improving, but there's a basic fact whether we actually, with early stage tumours that are sitting nicely in the parenchyma and are amenable to a surgeon chopping them out, whether they actually are not secreting ctDNA in any amount.
Yeah, but
and again,
actually,
whether there are other biomarkers, whether you can add in proteomic biomarkers. So all that remains to play for. But there is a sort of paradox that actually ctDNA in other realms we use as a metric of poor prognosis disease. So we use it to measure disease recurrence, or post-surgery for tumours that need more aggressive intervention, and so actually there's a sort of paradox of why it might not be a very good test for detecting treatable localized cancers. I would love if it were.
Multiomics is the answer, and now there are also some approach to stabilize ctDNA that might be useful in the future. So we will get to that. I mean, I'm sure about that. We have other questions?
Mm-hmm. We do. We have a few more. This next one is specifically for Professor Turnbull. It says tumor genetic testing is organized in different ways in different European countries, with some of them using a more centralized approach, while in some others it is more decentralized. What do you think would be the ideal scenario?
I think that's incredibly complicated, isn't it? Because you want rapid results, and ideally you want to have the opportunity for close interaction between your clinicians who are managing the patient, your molecular pathologists who are undertaking the molecular analyses, and ideally germline genetics as well, particularly if there are germline findings. So I think it probably depends on the organisation and geography, whatever design best allows that close communication. And I think we have all got much more, we all much more embrace telemedicine as the norm now. And I think that allows us to design molecular tumour boards much more efficiently, rather than trying to get people in a room, that we can have particularly tumour type specific molecular tumour boards and bring in the relevant expertise and get them. They may then occur over a much larger geography, but allow people to come together with appropriate expertise. So I think it very much varies country by country, geography by geography.
All right, wonderful. Thank you. We have one more here for Dr. Normanno. This one says, Europe seems to be more reluctant than the US to incorporate certain biomarkers, such as, for example, TMB in the case of pembrolizumab. What do you think are the reasons for this?
It looks like at least comparing the list of drugs that have been approved by FDA and EMA, that EMA is requesting higher level of evidence, which on one end can be reasonable, because I have to say some of these clinical trials are based on a few dozens of patients, and they are not really covering all the different histotypes. So it's very hard to accept that really these are tumor-agnostic drugs or tumor-agnostic biomarkers. On the other hand, we need to find a compromise, because there are drugs out there, the patients requesting to approach I don't think, no, in my country, we are going to organize molecular tumor board. Patients are tested with NGS, and then we use off-label drugs to give an opportunity to the patients. But I don't think this system is going to work. So I really think that we should organize clinical trials with the collaboration of the pharma. We don't want to pay for a drug that we don't know whether it's active or not. But if we go through clinical trials, we can accumulate evidence, information. We can really generate knowledge. At the end, we will understand whether these drugs can be really useful in patients with this rare disease, with rare genomic alteration. So I think that we have to find a compromise, hopefully also with the regulatory agencies in Europe, if we want to move on precision oncology.
All right, thank you so much. It looks like we have one final question here, so we'll go ahead and wrap up with this one for Professor Turnbull. What's your opinion on long-read sequencing for the detection of germline variants in tumor sequencing? Is it ready for clinical practice?
There's probably the utility of long-read sequencing would be more relevant to characterizing the somatically acquired alterations, so particularly complex rearrangements and fusions. The proportion of pathogenic variants that are of germline origin, that are genuinely pathogenic, that are constituted by complex copy number variants or so forth, is extremely rare. So actually, overall, the long-read sequencing would be helping your characterization of the acquired variants rather than adding large amounts of value in terms of the germline findings.
If I can add, the issue with the long read is that we work most of the times with the FFP tissue. So I think that's very difficult to standardize and to bring this. But let me I want to give a message to all the audience. You know, what we are observing is many patients are accessing to comprehensive genome profiling through clinical trials or other approach, which is fine. What we found is that almost never when potentially germline variants, we're talking about variants in BRCA, for example, almost never these patients are sent to genetic counseling. So please, if you find a BRCA variant in an NGS report, send the patient to the genetist, because he will then follow up, and if it's necessary, will go to a germline test. But this is really important. You know, our goal, the goal of Mission Cancer, is to reduce by 30% the mortality of cancer by 2030. We will never get back to this with new drugs, but we'll get to this with early diagnosis and with the preventive medicine. So this is really important that you understand the value and the importance of this, and you refer the patients to genetic counseling when you find any of these findings. If you have any doubt, it's better to send the patient to genetic counseling rather than, you know, just not taking this chance, this opportunity.
I think that, as Dr. Normanno emphasized, it's those variants, it's not about the technology, they're there. And if they are if they are pathogenic, looking them up, and if they're of a reasonably high VAF, as Dr. Normanno said, particularly genes like BRCA1, BRCA2, there's about an 80% likelihood, if you see it in the tumor, that it's germline in origin. So that it's around the pathways for referral and downstream management is the issue, rather than it being something that we're waiting for the right technology to come along.
Yeah, but it's not a matter of technology. I'm very aware that we found lung cancer patients or cholangiocarcinoma patients with BRCA variants that were confirmed to be germline. So we identify family, which we can reduce mortality of cancer up to 80%, at least in women. So I think this is something that you should take into account, even when we are doing the next day of comprehensive genomic profiling.
Yeah. And that 80% for BRCA1 and BRCA2 is kind of the same on tumor, off tumor. So whether it's a prostate cancer, breast cancer, ovarian versus
that's why I made this example.
That 80% is roughly about the same across tumor types. So BRCA1 and BRCA2, if it's of a acceptable, you know, a VAF above 0.2, 0.3, then it has got a good sort of 70-80% likelihood of being germline in origin.
All right, wonderful. Well, thank you again, Professor Turnbull and Dr. Normanno, for your time today and for your important focus on this specific area of precision medicine. We would also like to thank our sponsor, Diaceutics, for underwriting today's event. Before we go, I would like to thank the audience for joining us today, and I would like to remind everybody that our speakers are going to be joining the networking lounge here shortly for a continued discussion. You can access that session by navigating to the networking lounge within the virtual environment and clicking enter under the time 1600 to 1630. This will take you directly into the Zoom room for the continued discussion. As a reminder, this webcast can be viewed on demand. We will alert you via email when it's available for replay. We encourage you to share that email with your colleagues who may have missed today's live event. Until next time, take care, everyone. Goodbye.
Goodbye. Thank you very much.
Bye-bye. Thanks.